here. So he will try to convince us that we need endoscopic ultrasound to judge these lesions. And then we will have Dr. Lynn Debels, who is a fellow in our hospital, and she will try to convince us that it's the endoscopist who knows very well what to do with these superficial lesions, or how to judge them. After that, we will have a session on how to manage the superficial tumors. And with that, I would like to ask the first speaker to present the role of MRI in the rectum.
Good afternoon, everybody. It will be a very short talk, only 5 minutes. I will talk about the role of MRI in T1 rectal cancer staging, the role of MRI in the end-stage evaluation, and I will show you how nodal involvement is assessed on MRI. So I have no conflict of interests. So this is a sagittal and an axial image of the T stage of rectal cancers. I'm sure you all know this, of course, but I will only talk about the T1 and T2 tumors. So these are confined to the rectal wall. The T1 tumors invade the submucosa, and the T2 tumors invade the muscular layer, so the outer layer of the rectal wall. So how does the rectal wall look like on MRI? Well, the rectal wall is comprised of 3 main layers. So you have an inner mucosal layer with an intermediate signal on T2 weighted images. Then you have a middle submucosal layer with a high signal on T2 weighted images. And then you have an outer muscular layer with a low signal on T2 weighted images. And typically these 3 separate layers, they can only be recognized on MRI in the case of submucosal edema, which you can see here on the right-hand side image. So in the absence of edema, as shown on the left-hand side image, then the wall generally has a 2-layered appearance, where we can recognize the outer muscular layer, but we can hardly distinguish the mucosa from the submucosa. So I will be concise. Is MRI generally able to distinguish T1 from T2 rectal tumors? And the answer is no.
Okay, so I heard my 2 colleagues both say that they don't have the best imaging technique to improve the management of suspected T1 cancer, but maybe endoscopic imaging is the best modality. So first of all, I would like to say that the rectum is not like the rest of the colon, and that optimal management of early rectal cancer in modern colonoscopy is maybe the best, it's based on endoscopic imaging, especially to assess deep versus superficial submucosal invasion, and that's what we're talking about today. So the rectum shouldn't be treated like the rest of the colon. We know it has a different anatomy. The etiology of the polyps is different. They behave differently. And especially when it comes to treatment, there is a big difference in morbidity, which is very, very important for the patient. We know that polyps in the rectum, both for covert and overt suspicion of submucosal invasion, have a higher risk to be invasive. We saw this in one of the biggest studies of Burgess in 2017. So polyps in the rectum are at a higher risk to be invasive. So if we look at all the parameters for covert polyps, if you have a big polyp that is situated in the rectum and it has a big nodule, you should be aware of submucosal invasion. This is what for the covert submucosal invasion. This is also reflected in the guidelines, in the ESG guidelines. So you should always consider the location of the polyp. If it's in the rectum and you are suspicious of submucosal invasion, this is an extra factor that you should take in account. So here you have the three big groups. On the left hand side, you see a polyp that we immediately would go for endoscopic resection. We're not afraid to resect this, and I don't think this needs further evaluation. And on the right side, this is obvious an overt lesion with a clear demarcated area, and in this case, a demarcated area that is completely irregular. So endoscopic treatment is not on the table here. And in the middle, you have a bit of the gray zone. This is the covert submucosal invasion or risk of submucosal invasion, where you have this big lesion in the rectum with a big nodule. This is not really the scope of this talk, so I will not talk about covert anymore, but more about overt, and when there is a demarcated area, how we can know what is resectable and what is not endoscopically. David talked about this a lot today, and it is, as with every polyp, when you have a demarcated area, you should look at that demarcated area. If there is still some kind of regularity, so it's regular, irregular, JNA 2B, it is probably superficially invasive. So this is a lesion that could be endoscopically resected. On the right side, you can see the JNAT type 3, where there is not any regular pattern. It is completely amorphous. So this is a deep invasive polyp that is for surgery. As my colleagues already said, EUS is limited for the stage, and MRI cannot tell us if it's T1, T1A, T1B. So I think at the moment endoscopic imaging brings us closest to that estimation, but they might have a role, especially MRI for the end stage, and EUS maybe for the T1 versus T2 stage.
We've heard the rectum is different. We need an algorithm for optimal management, which in fact we've just had a live discussion there. There are some grey areas and there are still some turf wars, and maybe. I think the reason the rectum is different is because of the salvage treatment, and you referred to this earlier, where we get it wrong and then we need something else. And there is a risk here. I'll be interested in the surgical view here when we've intervened with an EMR and ESD, how much damage there is and how much fibrosis in the mesorectum. Should they then require ongoing surgery? And most of the surgery is ideally done laparoscopically here. So you're potentially ruining the planes, really. And we have several options for en-bloc resection. I was asked about definitive treatment versus optimal treatment. The optimal treatment is the right one for the patient, and actually a lesion in one patient might have a different approach to a lesion in another patient based on age and lots of other factors, and I think that's why the MDT is really important. So I think there are risks, and when we're doing this, you need to balance these risks, and that's why it can't be left to one person. Now, I put the modalities we've discussed. We haven't actually discussed CT, but if we think there's an overt malignancy, we do want a proper staging, and therefore I think you need CT in addition to MRI, and we keep the MRI because of the soft tissue enhancement in the rectum. That it shows that up really nicely, and I think you get the information you need. And going back to my previous point, I think if the endoscopic imaging suggests cancer is likely, okay, and at the end of the day, it's a binary thing. They either have got cancer or they haven't. But if you think it's highly likely, we probably want to stage it before we do anything else. And I understand Lynn going for just pure endoscopic, but I think there are some risks there, and it comes down to resource and availability because of the potential for inflammatory nodular enlargement. Mike, I know you're doing something, so I've got to be careful about overloading you, but have you got a view, and tell me what happens at Westmead?
Open, thanks. Well, we have every Tuesday we do 2 of these lesions. Often they're negatively selected, like this lady with a lot of comorbidity, and I mean, the best solution for her is endoscopic resection, no doubt. I mean, did you hear her story? Close slowly. I have to say, we never do a lesion this small. Usually we're doing things that are 5, 6, 8, sometimes the whole rectum. So, a lot of them, you'd think it's going to be cancer, it's just TVA low grade. even though it fills the whole rectum. And there are, and we showed in that study, which is published in CG8, of universal EMR versus, I don't know if we've got the data, but it's really worth looking at, versus a selective resection algorithm. So the last 170 cases like this that we did, mean size around 4 or 5 centimetre, not small like this, we cured all of the cancers that could have been potentially cured. All of those that were eligible. I think there were 35 cancers in that 170 cases. So, and amongst them, there were 7 eligible for cure by criteria. So SM1, no LVI, no poor diff, and no tumour budding. So they were all cured, and then we had a bunch that were fully staged, and amongst those, probably half of them didn't go off to surgery, but rather surveillance, because you know, they were too comorbid. So I mean, a high quality ESD gives you definitive tumour staging. Open, thanks. And then you can decide based on the patient's age and comorbidity and the family's wishes what should be done.